This is Dr. Gullingsrud of Edina, Minnesota, showing you a video of cataract surgery done on a person with a dense nucleus. I'm doing it under topical anesthesia, and I've just created an opening into the eye through which I can place preservative-free lidocaine. You'll notice how I also like to place it on the surface of the eye. This is all done for patient comfort. I'm now injecting a substance into the eye which is going to help create space that allows me to work and remove the cataract. It's called viscoelastic. I'm now using a device that helps the patient keep his eyes still. A lot of patients are worried about eye movement during surgery, and I always explain that we can help them through it. I'm creating an opening in the cornea with a 2.8 millimeter keratome. This is going to provide the entrance through which the cataract will be removed. Next, I'm going to be inserting a device which helps me to create an opening so that I can remove the cataract. I always explain that the cataract is very similar to a grape. It has a very thin external skin, and what I want to do is create a circular opening in the skin and then insert a different device to literally break up and suck out the fruit of the grape. I'm now inserting what's called capsulorhexis forceps to create a circular opening in the lens capsule. During cataract surgery, we're trying to create a uniform circular opening which is going to provide stability and centering for the lens implant. Hydrodissection is a means of using a fluid wave to physically break the attachments that adhere the fruit of the cataract from the skin of its surrounding capsule. I also want to mechanically use my hydrodissector to rotate the cataract before starting phacoemulsification. I'm now ready to remove the cataract with the phacoemulsification machine. You'll notice that I'll enter the eye with the tip bevel down, and then I'll use position 2 to vacuum the anterior surface of the cataractus lens. I like to remove cortex and epinucleus down to the lens nucleus. This provides me with a space upon which I can place the chopper to ensure that it goes around the lens during the lens removal process. I now rotate the phaco tip to the bevel up position. This allows me to start creating a deep central groove. A teaching point is that as I go deeper into the lens nucleus, I'm also creating a wider groove, which is going to allow the irrigation sleeve to go deeper as well. More dense cataracts like this one typically are thicker in circumference and diameter. Another teaching point is that as I advance the phaco tip deeper and deeper through the lens nucleus, I do so in such a way that as I go on my forward downward stroke, I'm in position 3, and with each backstroke, I'm in position 1. This will minimize the amount of ultrasonic energy placed into the eye and ensure that our patient has a nice clear cornea on their first postoperative day. I'm now getting ready to crack the nucleus. I do so in such a way that I place both the chopper and the phaco tip deep within the groove and apply outward pressure. I now rotate the tip of the phaco probe to expose maximum surface area to allow for the best purchase, which allows me to hold and chop the nucleus. I stress to residents that I use a take-it-as-it-comes approach regarding removal of the pieces. In this situation, I'm removing each separate piece as it presents itself. However, if they do not present themselves, I will chop into many small pieces, leaving them in the capsular bag and removing them at the end. If you look at my power and vacuum settings on the screen, you'll notice that I like to use a relatively low power and a relatively high vacuum. This allows me to remove each piece in as efficient a means as possible. Notice how that as I'm removing each separate piece, I'm keeping my second hand instrument, which is an olive tip chopper posterior to the phaco tip. This will ensure safety of the posterior capsule and avoid any forward movement to the tip should surge occur. The ozzel tip that I'm using on this case provides both oscillatory and longitudinal movement of the tip to break up the cataractous lens. As you watch the video, also watch the vacuum and power settings. You'll notice that I try to minimize the power settings while using a higher level of vacuum. Notice also the stability of the anterior chamber during this procedure. This is accomplished by the improved efficiency and the fluid settings of this machine. It also provides for greater patient comfort during the procedure, which is very important. You'll notice as I'm now removing the last few pieces, I'm also trying to take the epinucleus shell out with the phaco tip. This is a more efficient way of doing it versus using the INA tip. I'm now ready to perform irrigation and aspiration. I'm using a silicone tip here, which is nice for safety reasons. As I introduce the silicone tip, you'll notice that I like to perform a thorough removal of all cortical remnants as well as epithelial cells. This will prevent posterior capsular haze and thus YAG capsulotomies for our patients. I like to remove the subincisional cortex first and then move my probe more circumferentially than radially. This helps to ensure that we leave a clear posterior capsule before lens insertion. The subincisional cortex can be quite sticky, as you see here. However, the silicone tip allows me to be aggressive and remove as much as I can. It also prevents a break in the posterior capsule should occlusion occur. To use a sports analogy, I like to explain that during phacoemulsification, we're on offense, where we're actively trying to break up and remove the pieces of the cataract nucleus. When we do irrigation and aspiration, we're on the defensive side of the ball. We want to do a careful job of maintaining the integrity of the posterior capsule and preventing complications for our patients. I'm now preparing the eye for lens insertion by first filling the capsular bag with a cohesive viscoelastic and then a dispersive viscoelastic, which allows better protection and visualization. I'm now preparing to inject the lens. My assistant has loaded the lens in this sterile container, and you can see that as I slowly advance the lens through the container into the eye, we have a nice controlled movement facilitated by the viscoelastic remaining within the posterior capsule. Now that I have the lens implanted in the posterior capsule, notice how the haptics, which are the footplates of the lens, slowly extend into the periphery of the bag, thus providing good centration and stability for the patient. I'm now using the silicone INA tip again, this time to remove any residual viscoelastic from the patient's eye. We like to do this thoroughly so that there isn't an intraocular pressure increase on the first postoperative day. Typically during phacoemulsification, I like to use a dispersive viscoelastic, and for the lens placement, I like to use a more cohesive viscoelastic, which is easier and more efficient to remove. At the end of the case, I like to refill the anterior chamber with balanced salt solution to a point that's slightly above the patient's normal physiologic intraocular pressure. This will prevent bacteria from entering the eye postoperatively. At the end of the procedure, I like to hydrate both of my corneal wounds, which provides a barrier and protectant for the eye. If my wounds are well sealed, I do not have to place a corneal suture. I do like to place a topical anesthetic for postoperative patient comfort and an antiseptic to kill germs.